Um, Good afternoon, everybody. I'm Dr. Said from Marmara University School of Medicine. Maybe it's difficult to see, you can come closer if you want. I will be presenting our study titled AFS Endoscopic Grade as a potential predictor of de novo symptomatic reflux and PPI use after gastric sleeve. As gastric sleeve is the most frequent surgery in terms of weight loss management, and reflux remains one of the most important challenges after gastric sleeve. It's largely driven by the disruption of EG junction. And we know that based on the current literature, de novo reflux risks ranges between 25 to 40% after gastric sleeve. We know that based on the current literature, we know that pre-existing reflux has a great association with postoperative reflux. Okay, that's all. But de novo reflux is different. Imagine that the patient has no symptom, no clear sign of reflux, and we do the gastric sleeve, and after that, 25% to 40%, the patient will have reflux. Okay? So this is a critical important question, critically important. So accurate preoperative identification of patients at risk for de novo reflux is essential, but remains limited in clinical practice. We have some objective testing methods like pH meter, as you know, but there are some important limitations. It's hard to use, it's invasive, it's expensive, so it's very limited to use. So we use some endoscopic classifications. On the other hand, this is easy to use, more easy to use. This is accessible. For example, we routinely use preoperative endoscopy for every patient. So we have two classification systems. Hill classification, everybody knows that, I think, and more novel one, American Foregut Society endoscopic classification. Hill classification assesses only gastroesophageal flap valve, only valve system, okay? So this is a subjective system, but American Foregut Society system adds to gastroesophageal flap valve height, axial length, and opening, diameter of the opening. So it provides a better assessment and more objective evaluation and has a standard evaluation of EGG integrity. So in our previous study, we demonstrated that in the obese population, patients with obesity, there is a great correlation, great association with preoperative AFS grades and preoperative reflux. Now, in this study, we focused on postoperative reflux clinical outcomes. We investigated whether AFS grading can predict postoperative reflux and PPI use after gastric sleeve. So we plan a prospective observational study. We include only primary sleeve gastrectomy patients in this time period. This is a single high-volume bariatric center, and we looked at the postoperative assessment at 6 months, GERD symptom scores, GERD HRQL and RSI scores, because we have symptom scores in our hand, you know. There is no routine usage of objective pH meter testing. There's no data. There's no routine use. So we focused on clinical outcomes. What are the clinical outcomes? Symptom score systems and PPI use, PPI requirement. So this is critically important. Patients with established diagnosis of reflux, they are excluded from the study cohort, because if the patient has grade B esophagitis, grade C esophagitis, we do a further assessment. So it goes to further preoperative counseling, right? This is our institutional protocol. And patients with clinical suspicion, symptomatic patients, PPI users, esophagitis grade A, we refer these type of patients for objective reflux testing for better preoperative assessment. So we have the population with primary gastric sleeve patients with asymptomatic patients. So our primary outcome, the rate of PPI dependence, regular use, I mean everyday PPI usage, the rate of the PPI users, and any PPI requirement defined as regular plus intermittent users. Intermittent means on-demand usage. In a week, 2, 3 times, 4 times a week. These type of patients, this patient group, they don't go on without PPI users. Secondary outcomes, we compare the symptom scores between AFS grades. When we look at the results, the any PPI usage rate clearly has a stepwise increase across grades, as you see in the table. Grade 1, 0%, grade 2, 12%, 20%, and grade 4, 25%, any PPI usage. This is new onset reflux. I highlight that. So if the patient has grade 4 endoscopic classification hiatal hernia, the patient will have 25% risk of postoperative reflux. I think this is a valuable, important clinical key information. We have in total 229 patients. You can see numbers across grades, and you can see a clear stratification across grades. Grade 4 is better than has more patients than grade 3. A stepwise increase, a clear stratification. If we look at the symptom scores from grade 1 to 4, you can see the median numbers of the symptom scores, and in parentheses you can see the interquartile ranges. If we do the statistical analysis with Kruskal-Wallis, there is a statistically significant result. So the grades are different in terms of symptoms. Of course, we know that symptom scores, they are subjective parameters and they have a weak correlation with objective testing. So in conclusion, higher AFS grades were associated with increased reflux symptoms and PPI use after gastric sleeve, and AFS high-risk grading may help predict patients at greater risk of de novo gastroesophageal reflux. I would say may help because this is a preliminary study, preliminary results. You know, we have some limitations, as you see. We have only 5 patients in grade 1, relatively low. Please consider like this is a preliminary study. We are trying to generate a hypothesis. This is the nature of the study, hypothesis generating study. So from a clinical standpoint, we can say that this approach may help predict patients at great risk in terms of reflux, and maybe it provides better counseling and better patient and procedure selection. Thank you so much. I can have the questions if you have.
So that means that a patient with a pre-op in FS grade 4 should be performed a gastric bypass?
Yeah, actually it depends on the patient and surgeon experience, you know.
But you are advising that you have correlation between higher grade of AFS and PPI use.
Yeah.
Because the patient will have more reflux.
More reflux, yeah.
Don't do a gastrectomy.
So, you know.
What are you going to do? You have 1,000 patients. What are you going to do with that?
I would recommend clearly sleeve plus hiatal repair or one-way gastric bypass, of course, definitely. But it's not our question. We observe that if you don't do hiatal repair or one-way gastric bypass in grade 4 patient, you will have 25% with PPI users. It's a click. Yeah. 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 Definitely.
We recommend PPI use daily as a protocol.
We in our institutional protocol, 3 months regular use, and after the third month, we stop the PPI. So these patients, they cannot stop the PPI usage, okay? They are dependent. So, yeah, but I would recommend, yes, clearly, definitely sleeve gastrectomy plus hiatal repair or room-wide gastric bypass, better option. But sometimes, you know, with patients with clinical suspicion, they are suspicious and they don't want to have a hiatal repair because of the risk. So we will have relatively no low numbers in grade 4. Some of the patients for grade 4, they went to the room-wide gastric bypass. We include only gastric sleeve, but they are asymptomatic patients, but after the surgery, they are symptomatic. No correlation between
GERD or reflux and symptoms, and clinical symptoms. Pyrrosis or before, there's no clear correlation.
No clear correlation, definitely, especially in symptom scores.
It would be nice to have your pH treated. I know it's hard to perform.
It's, you know,
tough for the patient, but it's the gold standard.
Definitely. If we have objective parameters, objective data, but we don't have data. Actually, I would ask that you have any routine pH meter data on postoperatively? Do you have? I think no one has this data. Yeah, pre pre and post op. So preoperative for clinical suspicion, yeah, it's possible, but sometimes not possible generally. But it's very hard. It's expensive, hard to use, invasive, and patients don't want this actually. Yeah. Thank you. Yeah, good question. After the third month, after the routine usage of PPI, we recommend, suggest for all the patients to stop the PPI. Stop. After the third month, please stop the medication. It's enough after the third month. This is our institutional protocol. But these patients, they cannot uh, stop the medication. They need PPI. So we ask the patient, of course. We should trust. We have to trust. Sometimes regular usage every day, sometimes intermittent. So we have a two group, regular usage and any PPI requirement. So there's a clear stratification. This critical information is for only new onset reflux patient. The patient who has no symptoms, no clear signs, but after the surgery, grade 4, 25%, grade 3, 20%. Important. I think, of course, higher multiple studies with higher population is needed. Okay, yeah, this is a generating of hypotheses. We are looking for a pathway for assessing the postoperative risk preoperatively. Which patients will have postoperative reflux? We should assess preoperatively for appropriate patient counseling. This is a real question, I think. Yeah. You mean antihistaminic medications, right? We use only PPI. We recommend only PPI for reflux. Uh, yeah, definitely. Yeah. I think Dr. Fernandez says a similar one. PPI usage is not the same for reflux. This is not a diagnosis. I know this is a limitation, but we will just look around. Okay, PPI use, for example, in 14 patients, maybe one of them they use for gastritis, maybe not for reflux, but it can same in grade 3 for grade 2, but it's a limitation definitely. Yeah, thank you. Thank you.